Dr. Sumeet, presenting the glaucoma case. Dr. Sumeet Lahane, my son, who makes our all presentations, we present only. So from 2016, I have not made a single presentation. Mahipal sir, so I have not made a single presentation. So whatever the presentation is made, but by him. So if I will call this, मैं बुलाता हूँ, एक चेयर लेके आओ नीचे से, एक चेयर लेके आओ, चेयर, हाँ है ना, आइए महिपाल सर. Okay, go ahead.
Very good evening, everyone. I need to start from case 4. Can I take the control, please, here? Audio visual. वहाँ से कंट्रोल ले रहा है, ठीक है, उनको बोलो कुछ. I would like to thank Dr. Maya, our friend and colleague, for this case. It's a case of a 37-year-old male who came with the complaints of the mild blurring of the vision and the headache since 10 days. There is no redness, photophobia or any such previous episode, no history of glaucoma, no trauma, no steroids or any systemic medication. Patient had a vision of 6.6 in the right and the 6.9 in the left. And the anterior segment examination of the left eye showed cells and the flare congestion, and the pressure in the left eye was 40 millimeters of mercury, while in the right it was only 10. Angles were open, discs were healthy, and we considered the diagnosis of the uveitic glaucoma with or without trabeculitis. Patient was started on the steroids with cycloplegics. Also acetazolamide and the combination of brimonidine plus timolol. That reduced the pressure to 21 millimeter of mercury. After a week, after acetazolamide was stopped, pressure again increased to 40 millimeter of mercury. Again, anti-glaucoma were added and acetazolamide started. His CCT was also normal. This is the disc picture. And these are visual field which almost appear normal. And the OCT disc as well. Patient was kept on the follow-up. Pressure was constantly in the range of 30 to 40 millimeter of mercury, and he was on acetazolamide on and off. After 3 months, his pressure was still high, so prostaglandin analog was started. And after the max AGM, still the pressure is in 30 millimeter of mercury. This is at the end of the 3 months of the treatment. Now the visual field in the left eye has started showing changes. OCT started showing changes. And in this young patient, what do we do? Since we consider primary diagnosis of inflammatory glaucoma, is it juvenile glaucoma that we missed out? Is there any role of antivirals? Now there is a disc damage, so what are the treatment options? And do we operate him with or without steroid cover, or directly go ahead with the MIGS? Manish.
So definitely the initial presentation was a uveitic glaucoma and probably of viral origin, and it could be the amount of cells was reported to be a very low amount of cells. So there is something called as acute depigmentation of iris, which can be associated with high pressure. You get transillumination defects. That has not been studied, where it means it's not been reported in or observed.
In this case, yeah.
And sometimes they are associated with high pressure. Usually you treat, and it can resolve and come back. The iris pigments disappear, and the pressures goes down when the iris pigments disappear. In this case, iris pigments or the flare went away very quickly with steroid treatment, but the IOP refused to get controlled. And eventually, we are observing disc and field changes appearing too. Now, the role of antivirals would be there in cases where the uveitis would be active. So if the uveitis was difficult to control, and we could probably give antivirals. But here in this case, the uveitis went away almost in 1 week only. So I would not give antivirals just empirically. Antivirals also work best when given when the uveitis is active, when the virus is not in a dormant stage. So then you can give antivirals. Otherwise, he was treated with steroids and steroids were withdrawn. You have to consider steroid response. But when steroids were withdrawn, the pressure still didn't come down. So this is not a case of steroid response either. And for some reason, the pressure is not coming down. Now, once you have exhausted the options of medical treatment and pressures are in 30s, that is, and disc field changes are developing, you can't leave this patient, you will have to opt for surgery. Now, whether the surgery should be trabeculectomy or whether it should be a valve implant or it should be a MIGS surgery. So basically, I would not definitely go for a valve implant directly in this case because the uveitis is not very active, so there's not that much chance of fibrosis. So I would either opt for a trabeculectomy or an MIGS. I think it is if the angles he has reported are completely open. I think and the disc and field changes are mild. So it is out of the box. Actually, MIGS is not recommended in this subgroup of patients. But to save the conjunctiva and have the better future, if you need, you can do trabeculectomy. I would probably give a trial of an MIGS. Which MIGS I would do? I would prefer either a KDB or a GAT. But I am not very happy with GAT in my personal hands, so I would probably go for a KDB or a needle goniotomy if financial factors are playing a role.
Rashmin sir wanted to add something.
Yeah, I just wanted to ask, since there was a possibility the patient had uveitis, would you have started on prostaglandin analog? Because
so the person has reported very clearly that for 3 months, almost after the uveitis appeared, or almost 2 months after the uveitis appeared, he didn't give prostaglandins. And in uveitic glaucoma, if after the uveitis has resolved and you have observed for a good amount of time it's not active, you can give prostaglandins. But very important is when you give prostaglandins, you need to observe very closely, because I have had this personal experience. You give prostaglandins and within a week you get uveitis back, even after 2 months gap. So if you can observe, and the best thing is once you get the uveitis back, the pressure goes down. So if you just see pressure, you will miss the uveitis. So uveitis can come back, especially viral uveitis, known to recur with prostaglandin analogs. So if you are giving prostaglandin analogs, you have to be very watchful. Now you have the option of the ROCK2 inhibitors, which have reports of being suppressing uveitis. So before giving prostaglandin analog, after trying the timolol and all the standard things, my first choice would be to ROCK2 inhibitor before prostaglandin analog.
So, sir, yes.
Won't TRAB with steroid cover also be a good option?
Very good option. That's the only reason I said MIGS, because the patient is young and it is like just a trial. I would not, it is out of the box, it is not recommended in this kind of scenario. So MIGS, the people all over the literature suggests MIGS is best done for primary open-angle glaucoma of a mild or maximum or moderate variety, and which is well controlled on medications. It is not a good operation to do on patients whose pressures are very high. So this does not fit in the standard parameters. So if you want to go by very conventional, strict thinking, trabeculectomy under steroid cover would be the right thing to do. But now, we are willing to compromise a little, especially take the patients. There's no flip side. It's not in the ideal category, so it is likely not to work. But if it works and you get a little response, you get away from, putting a permanent fistula in the eye.
One question out of the context to Manish sir and the Rashmin sir both. So generally we give acetazolamide for a very short time because we are worried about the adverse effects. So in your experience, how long have you given patient on acetazolamide, sir? You for IIH cases maybe and you for glaucoma. How chronically have you kept patient on the acetazolamide?
for IIH can go up to 6 months or even more, and sometimes in refractory IIH you can go up to 2 grams if these patients, if they can tolerate. So such high doses can go on for 2 months or so, and then the treatment may have to be continued for 6 months or so. But of course, at that dose, a lot of compliance issues will be there.
So basically, the use of Diamox in patients, it's the full dose, as he mentioned. If you are going to give 2 grams or you are going to give 250 milligrams 3 times or 4 times a day, that is going to cause a lot of side effects in the form of the acidosis, and it can, so a lot of neurological, those burning sensation and tingling sensation, all that. But if you use a very low dose, surprisingly in patients who are already on maximal numerical therapy, and you're just toying the idea of whether, and especially if they have got problems which you cannot take for surgery immediately, give half a Diamox also sometimes has an effect, and it's very well tolerated, and giving it for a long time also seems to be quite all right. It doesn't seem to cause a problem. And patients for this kind of scenario, if you see neurological cases besides just hypertension, there people are giving just like patients who have had intracranial hypertension, which is secondary to other things like tuberculosis, meningitis, and things like that. People are giving Diamox for, I have seen for a year Diamox continued, and patients are able to take. The dose can vary. So we are sometimes can use Diamox, but you have to see how it works. It's not a standard recommendation.
I think in neurological cases, they are giving 1 year Diamox, they are giving. But Rasmin and Manish, day before, I think 3-4 days, I have operated one case, right eye traumatic cataract. He was a MLA. When he came to me in 2014, and that time his pressure in the eye was more than 56. So that time I have started him the IOPAR SR, BD, and then I have given him the, I think the Bidin tea and this one, I think the Travaprast, both. And then I told him, okay, we will operate once the pressure comes down. You come after 7 days. He came to me after 9 years. And 9 years, he's a MLA, big man. 9 years he was taking the IOPAR SR, and he was saying कि मैं गोली नहीं लेता हूँ. If I will not take this medicine, there is so much of the pain. For 9 years. So just now I have operated him. He's a traumatic cataract. Just now I have tackled after the 9 years of the IOPAR SR. So I think he was not having any problem with that IOPAR SR. But this is first case in my life who has taken the Diamox for 9 years. So I don't know what are the side effects in his body, but he has taken it.
Mantri bana abhi nahi.
Should I go on with one more case, or Zain has a refractive and cataract case? Okay, so I'll just quickly finish one more glaucoma case. Again, this is by Mayao sir. A 55-year-old male reported to OPD with the complaints of diminution of vision since 1 year. There was an episode of redness pain in the right eye 2 years back, and he is a known diabetic, not well controlled. Vision is 612/66. Anterior segment, there are few pigments on the endothelium and the anterior lens. Left eye is normal. Right eye fundo shows floaters with 0.7 CDR with the bipolar rim thinning. And there are no signs of diabetic retinopathy. Minimal exudates in the periphery, could be pars planitis. Left eye fundus is normal. Pressure in the right eye is 44, left eye is 18, and it's open angle. And this is what we see, if the picture is clear. On the superotemporal quadrant, you can see the subtenous deposit of a depot, maybe, or steroid. Considering the size of the deposit, is it conservative treatment possible, or the removal of the triamcinolone deposit should be done? Is there any role of surgery with the depot removal together, or do only a surgery?
So definitely you have identified that it is a steroid-induced glaucoma, other eye is totally normal, and it is the triamcinolone depot which has been given, which is responsible for it. And you have given maximal medical therapy, and pressure is 44, not showing any response to medical therapy. And there is disc damage already occurring. So there is no question over here. You have to get that pressure down, otherwise there will be serious consequences. So in this situation, the depot steroid was given how many? 3 months ago?
Yeah.
3 months back. So I have, in my experience, seen patients like this where we have operated and removed that depot steroid, and observe the patient for a short time, just a depot steroid removal, and observe for some time. Usually the pressure starts coming down, and if everything settles, then you can maintain on some anti-glaucoma medication if required, but if pressure settles very well, you need not do a trabeculectomy. So I am not sure whether this patient will need a trabeculectomy or not, and I am not very much in favor of putting in a filtering fistula without being really sure. So I would definitely aim for removal of the triamcinolone, continue medical therapy, observe for some time. If pressures don't respond and ultimately a trab is required, then we can do a trab as a second sitting. I would not like to do a combined, though I have to explain to the patient very clearly that it may be required.
Stepwise approach.
Yeah.
Thank you, sir.
Dogra sir, you put the implant. Acha.
Zen.
ठीक. I think my question to Manish is that when there is you can say steroid-induced glaucoma, it is said that if you remove the steroid or stop it, it continues.
So there are two phases of the steroid-induced glaucoma. Yes. One is the stage when it reverses, and the other stage is when after some time, if it has been there for exposed to steroid very long, it transits into actually primary open-angle glaucoma. So you cannot be always sure, depending on how much steroid he has used, and the steroid has been given, but for pars planitis, he may have used topical steroids also earlier, before the injection was given. So you can't be sure. It can continue also, the pressure can remain high. So we have to be very sure that if it does not come down, you will have to do a trabeculectomy.
Thank you, Manish.